I'm recording again. Okay, so now I'm gonna run through this. I got through 70 something slides in an hour. I can do it again. So for pharmacology, we have very important drugs, psychotherapeutic agents, or our anti-psychotics. I love this. I love psych. Besides cardiac, I like psych. But okay, so psychotherapeutic agents treat psychosis. I want you to forever know that psychosis or psychotic means hallucinations and delusions. Hallucinations are sensory problems, right? So they're hearing, seeing things that aren't really there, but they believe it's there. So we can't argue with them, but we tell them, we try to, revert them back to reality, but they believe that they see, an aircraft in the room. Delusions are false perceptions of thought, meaning they're thinking things incorrectly. So an example might be a delusion of grandeur, which means that they believe they are the king of the world, or they are the queen, or whatever. They believe they're the best person in the whole world, okay? They have delusions or false thoughts, all right? That's what I want you to remember for psychosis or psychotic, means hallucinations and delusions. Now, the drugs don't cure the disorder, but they help manage the symptoms. And some of these disorders include schizophrenia, bipolar disorder, narcolepsy, and attention deficit hyperactivity disorder, or ADHD. Schizophrenia has positive and negative symptoms. Positive hallucinations, paranoia, delusions, disorganized speech, and disorganized behavior, but it's mainly those hallucinations and delusions. Negative symptoms, they all start with A, which is really good in helping memorize it, but negative symptoms more or less have to do with social behaviors, right? Like how they behave, compared to positive symptoms, which more has to do with sensory things, or they're undergoing psychosis, okay? That's a little different. They have false perceptions of sensory or thoughts, whereas negative symptoms has to do with their mannerisms. So avolition, right? It means impairment to start goal-oriented activities. They might not be able to shower and things like that, or get themselves going to do things. They might have apathy or no interest and desire in doing things. They might have lack of emotional expression or anhedonia. That's what that means. And they might have something called mismatched affect, which means imagine going to a funeral and somebody laughing. That's what someone who has schizophrenia and is exhibiting negative symptoms would do. They might laugh at a funeral, which would be inappropriate. So their affect or their emotional expression is not appropriate for the situation. Now, schizophrenia has a lot of risk factors. Genetic association is one of them, a biochemical abnormality with dopamine and serotonin, okay? Bipolar disorder, we talked about depression. In my antidepressants, we talked about depression is caused by problems with norepinephrine, serotonin, or both, okay? So we're gonna see how these medications are gonna work on some of these receptors. Now, bipolar disorder means they have episodes of depression and mania, or both. So manic means, or mania means that they are super excited. I mean, they wear outlandish clothing. I mean, these people are like the Energizer Bunny, like all day, okay? And they're very competitive and violent. A depressed person, right? Very low life energy, right? They feel hopeless and worthless and things like that. And they could switch in between periods of this frequently. It's also potentially a biochemical imbalance or has genetic links. Narcolepsy means that they sleep a lot, okay? They have problems and they just kind of knock out and they sleep sometimes and they just have no ability to control that, okay? And it usually has problems with REM, and I've never heard of this, but hypocretin 1 and 2 may be deficient. I'm assuming that has something to do with our sleep cycles and the parts of the brain like the limbic system that control sleep. ADHD, the three main characteristics are inattention, hyperactivity, and impulsivity. We don't necessarily know why patients obtain ADHD, but Regardless, it could be genetic or environmental or problems with dopamine and serotonin. And you see how dopamine, serotonin are commonly, causing some of these mental health disorders? Think about that when we talk about receptors. Now, you could read this through, but I already highlighted some of the things that we're going to talk about that are children versus adults. So I did that for you already. Now, antipsychotics. Psychotic means hallucinations and delusions, right? That's what it can treat. First generations are typically more or less used for those positive symptoms in schizophrenia. Now, I wanted to separate this for you because I noticed in your slides they talked about typical antipsychotics and atypical, and there was no definition prior to that, so I wanted to provide that for you. So first generation are also called typical antipsychotics. It includes haloperidol or Haldol, fluphenazine or prolixin, or chlorpromazine. Sorry, I'm very bad at saying these, or thorazine. Those are examples of first generation typical antipsychotics. Second generation atypical antipsychotics are predominantly used for treating like negative symptoms of schizophrenia and things like bipolar disorder. This includes risperidone, zipasidone, clozapine, lonzapine. Okay, you could see there's a common ending here. And second generation is usually preferred more than first gen based on just the idea of the symptoms, okay? Now, what I want to tell you that's so important with those typical antipsychotics, I'm going to keep referring to Haldol because that's one of the most commonly asked ones, or haloperidol. It can cause EPS or extrapyramidal symptoms. That means they have problems with movement. So ataxia, which means restlessness, dystonia, which means that the muscles contract involuntarily, or Parkinsonism. They get like Parkinson disease, like a shuffling gait. These three are reversible. That becomes very important, especially when we talk about anti-Parkinson agents. Tardive dyskinesia is irreversible. It's an irreversible symptom of EPS, which means that they have facial and body movements like lip smacking, okay? That is irreversible. But reversible symptoms of antipsychotics, of those typical antipsychotics like Haldol, anti-Parkinsonian agents are reversal agents for EPS. These are our anticholinergic drugs like benzotropine or trifexylphidine, or an antihistamine like diphenhydramine. All of these three are anti-Parkinson drugs, meaning we can use them to treat signs and symptoms of Parkinson, which makes sense, right? If an EPS symptom of a typical antipsychotic is a shuffling gait or Parkinson-like symptoms, it would make sense that anti-Parkinson drugs can be used to help reverse these symptoms. And I want you to know that because when you are on an exam, it might ask you, a patient is taking a typical antipsychotic like haloperidol, or they might just say haloperidol. And they're experiencing extrapyramidal symptoms. Which drug can the nurse give to help reverse the extrapyramidal symptoms or the symptoms, right? You would need to be able to know these three. One of them will be the answer. Okay. Now we have atypical antipsychotics like risperidone. Okay. These can cause, if some reason there's an interaction in the body, these can cause metabolic syndrome, which causes increased weight, increased blood pressure, increased blood sugar, and increased cholesterol levels. What does that mean? I got to monitor my labs. I got to monitor my metabolic panel. I got to monitor blood sugar, and I got to watch the vitals and daily weights. Okay? Now, generally for antipsychotics, they typically don't separate them so much because there's a lot of similarities, but I wanted to highlight it before so this part makes sense. The therapeutic actions for typical antipsychotics like haloperidol block dopamine receptors. Remember, we said dopamine or serotonin can be the causes of some of these mental health disorders. So they prevent stimulation of these neurons, which essentially helps with some of those positive symptoms in schizophrenia, right? Atypical antipsychotics block both dopamine and serotonin receptors, which means it could help with bipolar disorder and negative symptoms of schizophrenia, because dopamine and serotonin are some of the things that can affect your mood, like depression, and it can cause that, or mania. Now, like I said, we talked about the signs and symptoms of schizophrenia. That's one of the reasons why we might give an antipsychotic, right? Depending on the symptoms. And we can give, like I said, those atypical ones like risperidone for like bipolar disorder. But what pretty much with pharmacokinetics, I just want you to know that, okay, right? It's usually an IM dose. Okay, so you can give it as an IM, which is, or an intramuscular, which is really good, because imagine being a patient who is having hallucinations and delusions, or you're a paranoid schizophrenic where you think people are out to get you, right? So it would be good if they have an injection that comes weekly and they know the person and they know where to go. And it might also increase medication compliance. Remember, the only way to help these patients is for them to adhere to their medications. If they're not doing that, it's not going to help. So if they stop it, no good. Okay? That's what I just want you to understand with this. Okay? So we can give them oral or IM. And it crosses the placenta. So always rule of thumb for 99% of the medications, contraindication, pregnancy, and lactating mothers. Contraindications. The QT interval and that EKG can become elevated as a result of some of these antipsychotics like Haldol. So we have to watch EKGs. Okay, so we have to also be careful with other dopamine blocking effects, because too much could potentially cause things like, right, like those EPS, and it could really cause really bad adverse effects. Other things are seizure disorders, because these work in the brain. So we don't want to give them these, because these could affect the way seizures work. Active alcohol use disorder, remember pregnancy, and immunosuppression. Okay, but definitely that QT interval for Haldol. That's an NCLEX question right there. I already know you're going to see that somewhere. Okay, so once again, antipsychotics or neuroleptics, these are what they generally do. But things that we're also going to look at, right, is adverse effects. If it works in the brain, CNS. Anytime, all of these drugs work in the CNS, so you should already be saying adverse effects, CNS, like lethargy, depression, and potentially respiratory depression. That's your priority, so you always should assess that respiratory status. That should be your answer if that's on a test. I don't care. That's going to be your choice. That's what you're going to pick. And adverse effects are related to the dopamine blocking, or if they're anticholinergic, like some of those reversal agents, we have that anti-slud, so we have to be careful with that. Drug-drug interactions, alcohol is also always one of the ones that interacts with everything. Anticholinergics, right? You shouldn't use two or more together, right? We shouldn't use too many at the same time. And ziprasidone and torazidine, besides Haldol, can also cause that prolongation of the QT interval, so you better watch your EKGs. Okay. So bipolar disorder also, like I said, includes some second-generation antipsychotics and lithium. Lithium is a mood stabilizer, typically used especially when patients experience manic symptoms. Remember, they're all over the place, so the lithium is going to help calm them down. So lithium is a very, very important drug and has very important nursing considerations. So Lithium affects sodium transport in the nerves and the muscles. Sodium is one of those, electrolytes that affects the action potential in nerves, or the nerve's ability to work. So if we can lower or alter the sodium, it can help reduce the mania. Okay? It inhibits the release of norepinephrine and dopamine to help reduce the episodes of mania. That's what I want you to get away from this, okay? Contraindications: if they have an allergy or hypersensitivity to lithium, renal and cardiac issues. Remember, because these play a big role with electrolytes, so we got to watch out for that. A history of leukemia, metabolic disorders, dehydration, pregnancy, lactation, and anything that can alter sodium levels, right? So this might not be such a good idea to take with what are diuretics, because they're going to affect sodium levels. Things to think about. Now, this slide is the most important slide out of everything I spoke about with lithium. The problem with lithium is it's one of those drugs that has a very narrow therapeutic range. I'm talking only from 0.6 to 1.2. Over 1.5 means they have toxicity. And they're excreted through the kidneys, right? So we have to really watch sodium levels. We need a metabolic panel constantly. You need to know what happens at all of these levels, or what can happen if they are having a blood level of less than 1.5. Let's just say 1.4. They could have CNS problems, polyuria, or gastric toxicity, something wrong with the bowels. If the level's between 1.5 and 2, they could have EKG changes. If it's between 2 and 2.5, we have more CNS effects, more cardiovascular effects, dilute urine and renal toxicity, and pulmonary toxicity. So you see how the symptoms are increasing. Over 2.5, multi-organ almost failure and death. So what do we educate our patient? If they're taking lithium, they must monitor their blood levels very frequently. They must get their blood drawn a lot, because if this drug is not in the therapeutic range, it can be lethal. Lithium interacts with a lot of things like haloperidol, neuromuscular blocking agents, but like I said, the primary thing I want you to focus on is what I spoke about before. And these are just some of the other drugs that it can interact with. Now, I added this in. ADH, we said, is right, they're inattentive, they are impulsive, and they have hyperactivity. Now, we give them something called psychostimulants. These cause a paradoxical effect by creating symptoms. They recreate the symptoms that they're experiencing, which in return actually manages the restlessness. Now, this is where I pointed out which we give for kids and which one we give for adults. So for kids, we give methylphenidate or Ritalin. Okay, you've probably heard of Ritalin, or Concerta, which is an extended release version. If you give Concerta, what should you tell your patient? This is a long-acting, only a once-a-day medication, so they can only take it once a day. The school nurse should know that, and anyone else who interacts with this patient. Okay, and these are controlled substances, meaning they have a potential for abuse. Drugs for adults that have ADHD include amphetamine or dextroamphetamine salts like Adderall, or atomoxetine or Strattera, and they're all controlled substances. So I would know Ritalin and Concerta for kids, and amphetamine and or Adderall and atomoxetine for Strattera, or that's what is also called Strattera. Actions. How does it really work? Well, they're stimulants. As I said, they produce paradoxical effects by increasing the symptoms that they normally get, and in return helping with the restlessness. That's how these drugs work. So they block all that stimulants, and it really does help. Okay, and these can also be used for narcolepsy, because the reason it can be used for narcolepsy as a part of the nursing interventions that I'll get into in a little bit is that it can cause insomnia. It can keep you up. So if you're giving them a medication that's going to keep them up, they might not be falling asleep as much as they normally do in narcolepsy, which could be really good for just getting through your day. So drugs for ADHD, we already talked about the types. They're, always allergies, pregnancy, history of seizures, pretty much anything with CNS, you got to be careful with seizures, okay? Adverse effects, CNS, GI, cardiovascular, but especially those CNS, right? Because it penetrates the CNS, these drugs. Drug-drug interactions, MAOIs, and TCAs. Why? Because they're CNS acting drugs. Antidepressants work in the CNS and depress it. This can be really bad. No caffeine and no over-the-counter medications. But what I want you to know, especially, is adverse effects for CNS, which ones you give for kids and adults, and what do I teach my patient? I want you to tell them, do not give your kid any of these drugs, or an even adult, do not take this after 6 p.m. because it causes insomnia. It can affect growth and development, especially for children with Concerta and Ritalin, so they have to watch out for that. So we want to keep a growth chart and monitor that. Monitor blood pressure. It can cause blood pressure changes, and blood work, okay, because it could change electrolyte values. Any questions? No. Okay, I always take silence as no. Okay, so Parkinson's disease. We spoke about anti-Parkinsonian agents that are reversal for those EPS. So there's a lot of things that overlap. But Parkinson's, we don't really know why it's caused. Usually people who are entering their 60s, could be genetic or environmental, but key thing, no cure. Typically, shuffling gait, slow slurred speech, rigidity, and weakness are common manifestations of Parkinson's disease. Signs and symptoms, or the reason why Parkinson's disease happens, is there's some sort of damage to the basal ganglion. We don't know why, but something happens here, and that affects some of those dopamine receptors, okay? So the goal with these medications is going to balance dopamine and cholinergic neurons, which is what the basal ganglia controls. And like I said, what can cause it? We're not really too sure. Maybe drugs, environmental factors, maybe a TBI, things like that. So remember, therapy is aimed at restoring the balance between dopamine and cholinergic neurons, okay? We want also, because this is going to be a progressive disease, we want them to be active so it could help slow down that progression. If they're living a sedentary lifestyle, the weakness and the slowness that they're getting in their gait is going to be worse. They need to perform daily exercises, take care of themselves, and follow their drug protocols, okay? Now, like I said, you could definitely read this over, but if a child needs an anti-Parkinsonian drug, we can give them diphenhydramine. And diphenhydramine is one of those reversal agents for EPS. For adults, we can pretty much give them everything, and always with older adults, they're at risk for adverse effects, so we just have to be very careful. Okay, this is just showing how these drugs work in the neuron and that basal ganglia to help increase the activity of dopamine. So all of these drugs that you see here act on dopamine to increase it to help slow the effects. There's no cure. We can only help slow or mitigate the symptoms. So we have levodopa, carbidopa, levodopa, resagiline. I don't know how to say it, but I've seen that one when I was tested. So those are some of the ones that I've seen predominantly, but they're all important, but I'm just trying to highlight at least the ones that I know would probably show up on your exam. Remember, they work on dopamine, so they help increase dopamine and prevent it from breaking down. That helps that restore balance in the neurons in that basal ganglia, okay? And it helps relieve symptoms of Parkinson's disease, okay? Remember, if it's metabolized in the liver and it's excreted in the urine, contraindications would be liver and kidney problems always. Any allergies, always a contraindication. And for levodopa, patients who are taking levodopa, you really have to be careful with the MAOIs. Now remember, MAOIs, you can never take them with another drug. You have to have a washout period of 2 to 3 weeks before you can take an MAOI. So, we just got to be careful with those in general. Cautions, right? Cardiovascular disease, right? These work on dopamine receptors. We're kind of starting to simulate those sympathetic and CNS effects. So if they have really bad cardiovascular disease, this can be a problem, right? Asthma can be a problem. Psychiatric disorders can also be a problem because we're working in the CNS and we're increasing dopamine, which can have a negative effect on someone who has like psychosis or the things that we spoke about already, and pregnancy. Adverse effects, right? If it works in the brain, we're talking about CNS. Gotta watch respiratory rate. Drug-drug interactions, always any herbs. This can be a question on your exam, even though it has nothing to do necessarily with CNS. It has to do with pharmacology and understanding it as a whole, right? If the patient is about to start a new medication, but they take herbs, what should you do? Confirm with the healthcare provider before they start any of their medications, because there could be an interaction. For carbidopa, levodopa, watch out for iron salts. They interact. And rasagiline, thiramine containing foods, right? Remember, MAOIs don't like thiramine. So if I'm going to give them rasagiline and MAOIs, that can be a really bad interaction. St. John's wort is also one of those really common herbs that interacts with a lot of things. That's another one I would point out to remember, hey, St. John's wort is not good with a lot of medications, okay? Meperidine and acetaminophen. But I would remember thiramine containing foods, that's like everything, right? Those aged cheeses, those wines, those salami, pastrami, those like all of those like cold cut or those kind of meats, things like that. No yogurt, no fermented yeast, all of that. Now, we already talked about these, the reversal agents for typical antipsychotics. Now, diphenhydramine, remember, is an antihistamine. It's not an anticholinergic agent, but benzotropine and trihexyphenidyl are. Remember, anticholinergic means anti-slud or anti-salivation, lacrimation, urination, defecation, digestion, which means that's already one of your adverse effects, anti-slud. Remember, this is anticholinergic. Cholinergic is normally working on those parasympathetic system, but these block those muscarinic receptors, so we have more or less sympathetic-like stimulation. It helps treat Parkinsonianism, and it relieves extrapyramidal disorders associated with some drugs. You see how everything comes back around? That's why I'm happy I spoke about it earlier, because everything's making a full circle. So, anticholinergics, right? Once again, metabolized liver, excreted in the urine, crosses the placenta, contraindications, pregnancy, whatnot, right? Tachycardia, dysrhythmias, because it increases sympathetic-like stimulation. Hyper or hypotension, this is also could be called labile, or what labile means changing blood pressure. Hepatic dysfunction or liver dysfunction and things like that. Also myasthenia gravis, because myasthenia gravis, we need cholinergic drugs to treat myasthenia gravis, which is like a problem with the muscles, and it causes like weakness, but it's more of an immune problem. So we're not going to give anticholinergics to someone who needs a cholinergic like drug. Now, adverse effects of anticholinergic are anti-SLUD. If they were cholinergic drugs, the adverse effects would be SLUD. CNS, because it works in the CNS, parasympathetic system. Okay, watch out for tachycardia and palpitations because of that sympathetic-like stimulation and potential hypotension. The urinary retention and hesitancy is from that sympathetic-like stimulation. Drug-drug interactions, other anticholinergic, right? If you're given 2 at a time, oh my God, they may never go to the bathroom, or they might have, CNS depression, or, we don't want that. And antipsychotics, okay? But, right, if it's the antipsychotics that are causing that EPS, then we use it, okay? So, now another drug that I've seen before is Segaline, which is if other things don't work, we give this in adjuncts with other Parkinson-like agents or anti-Parkinson agents to help improve the reduction of symptoms. So usually Segaline is used with carbidopa-levodopa after patients have shown signs of a deteriorating response to the treatment, okay? I would also look at some of these, but I just wanted to let you know that's the one I've seen before. I see there's a question.
Hi. So, the Siligaline, is that not an MAOI medication?
It is. I think it is. I've seen that one. Yeah, it is.
And we're not supposed to give that with other medications. So
Yes, but I
why?
think the way this one works, it's not like the other ones. Um, it doesn't have as strong of effects. And don't forget, these are patients who are having a deteriorating response at this point, right? This is when their symptoms are getting really, really bad. So this is just kind of to help. And remember, MAOIs are always used as a secondary choice, right? We were talking about with antidepressants, we don't really use them. We don't want to use them. But with carbidopa-levodopa, it doesn't really have a bad interaction. Does that help?
Yeah,
Okay, I just want to make sure, because sometimes I'm like, I don't know if I'm explaining it in a way that makes sense. But yeah, that was a good point. You're like, if it's an MAOI and it interacts with everything, why am I gonna give it? But it's one of those situations where it is like a last resort sort of thing. This is, like I said, only when all traditional therapies haven't worked. So this is in a hopes to at least mitigate symptoms while they're deteriorating. Okay. So, is there any other questions before I start anti-seizure medications?
Just really quick about the dopaminergics, the ones that regulate the dopamine. Are they're
Okay.
increasing the dopamine?
Yes. Yeah, they're increasing the dopamine so that we can have reduce the effects of the neurotransmitters breaking down. So the neurotransmitters are breaking down, and neurotransmitters include dopamine. So when we prevent dopamine breakdown, we're restoring a balance between the neurons, that synaptic gap, because like the neurons are breaking down and everything's decreasing. But if we can increase dopamine, that's going to help create a little bit of a balance to help mitigate the symptoms.
Okay, thank you.
Yeah, so the dopamine, I don't know how to say that, but these promote dopamine synthesis, okay? They increase it. But remember, MAOIs, even though they would block norepinephrine and serotonin, they don't block dopamine. So you can give an MAOI because they're not going to affect the balance of dopamine in relation to like carbidopa, levodopa, because it has no interaction on the dopamine receptors. But yes, we need to increase dopamine to help with Parkinson symptoms. Okay. So now we have anti-seizure agents. I know it's a lot, but I'm trying my best to make it as easy and understandable. So Parkinson's, we need to increase dopamine, or we can give anticholinergics, right? For antipsychotics, the problem is that we have an interplay of like too much dopamine and too much serotonin and things like that. So we need to help calm some of those down. But if it's like a bipolar disorder and they're in manic or they have mania, we need to give them lithium, which works on sodium to help stabilize the mood. I hope that was an okay summary for what we just talked about. But okay, the last thing is seizures. Now, with seizures, all I want you to understand about seizures is that it's an abnormal and sudden increase in electrical activity in the brain. Okay, so like it's really stimulating your brain and it's producing more electrical stimulus than needed. So your brain sort of freaks out, and that's where the seizure occurs. Okay, there's multiple theories as to why, but nobody's 100% sure as to why a seizure might occur, especially depending on the type, right? They could be structural or impairments of the cell membranes and certain neurons, but regardless, there's a problem with the electrical activity and the neurons. Now, I really thought this was important, and it wasn't in your slides originally, is the stages of a seizure. So we have prodromal, which means symptoms start before seizure activity. There's going to be some sort of indication that they might have a seizure. Now, a warning sign that a seizure will occur is something called an aura. It causes sensory stimulation. So they might say, "Do you smell that? I kind of smell something weird." Or, "Do you see what I'm seeing over there? Do you taste that weird funky taste?" If they're having some weird sensory altercation, that's a sign that, hey, they're going to have a seizure. If they have problems with vision and they're becoming dizzy, those are all indications that they're going to have a seizure. Now, itis is when we have status epilepticus, and that's when the seizure lasts more than 5 minutes and this person goes unconscious during that seizure. After it, right, that's why during seizures it's so important, because they become unconscious and they don't know what's going on. We need to have padding on the rails, right, and watch out for their respiratory status and making sure they don't choke on their own saliva, because they don't really know what's going on. And 5 minutes is a long time. So post-seizure, we got to look at how they're doing. Was there any injury? They might have a little state of confusion and things like that. Epilepsy is a unique type of seizure because it's a chronic disorder comprised of multiple neurologic disorders. It also causes, like I said, a seizure is an abnormal amount of electrical energy. And that's what this is, but it's just caused by a multitude of things. It's not just one specific thing. And that's why epilepsy is very scary. For seizures, we have other types. We have focal, which means localized or one part of the brain, and generalized seizures, meaning they encompass different parts, all over the brain. Okay, so localized is one part of the brain and generalized is like all over. So we have simple partial, which is where sensory and motor symptoms occur. We have an aura, some sort of sensory, like, this smells weird, letting us know they're going to have a seizure. But they're aware of the environment, which is really good. They know what's going to happen, and they're able to tell you what's happening. Complex partial means that they lose consciousness, and they don't know what's going on for a focal seizure. For generalized, meaning all over the brain, we have a few different types. We have tonic-clonic, also called grand mal seizures. They also have an aura, but the stiffening, or they have tonic stiffening and clonic rigidity. So they're rigid and stiff. That's what tonic-clonic means. So they're rigid, stiff, and they're having a seizure, okay? For absent seizures, it's just a blank stare. Like, I don't know, I do this a lot, but sometimes I just stare off into space. I don't have absent seizures, but an absent seizure is when they just kind of blank stare for a few minutes and then they come back. There's no like seizure precautions the same way you would with the other ones. Atonic is when they lose muscle tone. So imagine like, they don't know the seizure's going to happen. Then they drop the cup because they lose muscle tone and they fall to the floor because they just lost all their muscle tone, just totally collapsed. Their muscles just stopped working. So those are just some of the types of seizures. So we already went over the different types. You could have also febrile seizures, right? So when your fever gets really, really high, you can also seize. That's why you have to be really careful. We already talked about status epilepticus, where they have unconsciousness for over 5 minutes and things like that. Monoclonic is very similar to tonic-clonic. They just have more like stiffening. So this is just the way that the International League Against Epilepsy categorize their seizures, right? Are they aware, or do they have impaired awareness? What's going on? Generalized, right? What sorts of seizures? And when we don't know the known onset, like tonic-clonic, that's one of those seizures that we don't really know why they get it. Now, for anti-epileptics, meaning if they have epilepsy, remember it's a chronic disorder comprised of multiple neurologic disorders. Typically, it's really hard, but phenobarbital is great for kids. Now, phenobarbital is a barbiturate that we talked about as an antipsychotic. It causes CNS effects and has an increase for physical dependence because they can be highly abused. So phenobarbital is the drug of choice for tonic-clonic seizures, but these tonic-clonic seizures, like I said, every seizure can be very scary. But with these, this is the drug of choice for it. But if this patient has a history of dependence or let's just say a history of addiction, right? They become easily addicted or dependent on substances. Phenobarbital would not be the drug of choice for that patient because this drug can be highly abused, and that would probably not be a smart idea. Adults can pretty much use anything, and older adults, you just have to be really, really careful. Okay, so now we're going to talk about drugs that treat generalized seizures. And what I want you to know, it's so hard to see, but you're going to notice that there's going to be a few different ways that these anti-seizure medications work. It's all in the brain. So every adverse effect for every class of drugs that we've been talking about, because they're all CNS drugs, or CNS effects. So get that engraved in your head and watching out for respiratory static, because CNS effects could also lead to respiratory depression. But barbiturates are an interesting class because they mimic this receptor called GABA, or they actually bind to it. Sorry, they bind to this receptor called GABA, which is in our limbic system. Our limbic system is a part of the brain that causes our hunger, thirst, sex drive, our emotions, all of that stuff, right? And basically, when we mimic GABA receptors, we are essentially causing these chloride channels to open, and we're relaxing the muscle. That's where that CNS effects come from, right? So if we relax the muscle, it relaxes. Everything might relax a little too well. Your lungs are muscles that might relax too well. Your heart might relax a little too well. That's why you got to watch out for bradycardia and all of those things. Benzos also work on GABA. Vaporic acid also works on GABA. A lot of these work on GABA, or they can affect sodium and calcium channels, because sodium and calcium, right, affect those action potentials in the neuron, in the synapse, right? So if we can alter the levels, if we can decrease sodium and calcium in that synapse, we can help reduce the electrical activity and help with the seizure. Now, one class that's used for generalized seizures are these hydantoins. They all end in toin, and the most commonly one I've seen is phenytoin. These are great for a patient who has a history of addiction because they're generally less sedating and they're less likely to form dependence, okay? So this is really good. This is good for our patient who has a history of addiction. These also reduce tonic-clonic seizures, okay? This is the type of seizure that usually you would use phenytoin for, okay? And these stabilize the membrane by influencing those channels, right, where we have that sodium and calcium interplay, and it causes that because sodium and calcium are causing the excitability. So if we can inhibit those and decrease the excitability, we help with the seizure. Now, all of these, right, they can be given in different forms. What I really want you to know is, right, the adverse effects and when we don't use them, right? Always pregnancy, always allergy, always renal or liver impairment, right? And anybody who's in a depression or having psychosis or coma, they're having CNS depression already. So if we're going to give them a medication that can also further CNS depression, no good. And you're going to see this repeat. And these like contraindications are going to repeat in every single class that we're talking about. Same thing with pretty much the adverse effects. Every single one is going to say CNS depressions. And what's going to be our drug to drug for every single class? Alcohol, narcotics, and CNS depressants. Why? Because these also depress the CNS. So we don't want to give them anything that's going to further that. Like alcohol is a CNS depressant, narcotics like opioids, morphine, CNS depressants. Our friends like the benzos, you don't want to give them with these or barbiturates, things like that. Barbiturates all ends in barbital. Phenobarbital, another one that I said is a drug of choice for tonic-clonic seizures unless the patient has a history of addiction and significant CNS depression and dependence, okay? So we have to be so careful with these and warn them, do not take more than your prescribed dose. They can be very addictive, okay? So these mimic GABA. They don't work on GABA, but they do the same thing. They open those chloride channels to relax the muscle, which means they can relax everything too well and everything can start slowing down a little too much. Okay? It's absorbed well in the GI tract. It's metabolized in the liver and excreted in the urine, which means we need good liver and kidney function. It has a slow onset, but once it's in, it works. So, contraindications and cautions, right? Same as a Atones, right? All the things we talk about, the comatose, depression, pregnancy, all that stuff, it all is going to repeat again. CNS depression, an adverse effect. Physical, but what's unique to these barbiturates is that physical dependence, right? And it can cause a lot of symptoms of withdrawal if they even try to stop taking this medication, okay? And what are drug-drug interactions? Alcohol and other CNS depressants. It's going to repeat. So for benzos work really quickly. And what I want you to know about these are anti-epileptic. So if I was making my notes, I would say, okay, the hydratones are good for tonic-clonic seizures when a patient has a history of addiction. Barbiturates are good, especially for children, but they're highly abused and can cause physical dependence. So I have to really watch out for that. What I would write on my side is that all of these drugs cause CNS effects or potential CNS depression. So I got to watch out for respiratory rate and cardiac rate, all of that for all of these classes of drugs. For benzos, they all end in Zapam or Zam. They're also very highly abused and highly addictive, but they're anti-epileptic. What's good, though, about diazepam is they work so quick that they can actually stop a seizure while it's happening. That is unique to the benzos, especially diazepam, okay? So therapeutic, what does it do? Works on GABA. What does that mean? Opens those chloride channels, relaxes the muscle. CNS suppressant, okay? It can be oral or rectal forms. Once again, they work very quickly, these drugs, okay? Especially if we give it like rectally and things like that, right? Because the rectal forms would be closer to the blood flow because there's a lot of blood flow that we have running through our rectum. But anyway, so contraindications repeats again, right? All of those things that we spoke about already, I would just write adverse effects and contraindications for one on one side because everything just repeats. Literally, all of these contraindications, allergies, pregnancy, lactation, impaired use with older adults, impaired liver, renal, coma, depression, psychosis, it's just going to keep repeating. So if I were you, I would make a page of this. It would already help you organize everything. You'll just have to start figuring out the select differences. But with, like I said, those benzos and barbiturates, the unique thing with that is besides causing, CNS depression like everything else, they can cause physical dependence and withdrawal. And what are my drug-drug interactions for all of these classes? Alcohol, CNS depressants, opioids, or narcotics like morphine. Succinamides treat those absence seizures, okay? Oh, and I said benzos are for epilepsy. But succinamides are for those absence seizures where you're staring off into space, and these end in succinamide, okay? So that's going to let you know this is a succinamide. Now, what do? They suppress that abnormal electrical activity, because remember, seizures are caused by abnormal electrical activity in the brain. And basically, it inhibits those neural pathways, so it affects those like sodium and calcium for that action potential and slows everything down. So they cross the placenta. So once again, pregnancy, all of these things keep repeating. It's like, I shouldn't even add them on here. But anyway, known allergies, watching out with renal or hepatic disease, pregnancy, or breastfeeding, right? And that's the main point with these adverse effects, CNS depression. Also, any drug that you see, if it causes increased risk for suicidal behavior and ideation, that is scary. So for this drugs, I really want you to know that, which means you must monitor their mental status, right? Ask them, how are they doing, right? How are you feeling? If they give you signs or cues that they might be suicidal, they say things like, I don't want to live anymore. You don't have to worry about me anymore. They start getting their affairs in order. They give away their prized possessions, like things that they actually find dear. If they start doing these things after taking this medication, they better be on 1-to-1 within an arm's reach. So suicide precautions better be here. Okay, so those are the two things, the CNS depression and the increased risk for suicidal ideation. Like I said, this one compared to some of the others does cause GI effects, bone marrow suppression, maybe some rashes. But if I were you, the two main ones would be the CNS depression and the increased risk for suicidal behavior. Now, we also have drugs that might work on those GABA receptors. This is a very famous receptor when you're talking about these seizure medications. The ones I've seen a lot is valproic acid and acetazolamide. So valproic acid reduces the abnormal electrical activity in the brain, increases GABA activity, which opens those chloride channels and relaxes the muscle. Acetazolamide alters the electrolyte movement, so those sodium and calcium, okay? The other ones work on GABA, so Zioproax works on GABA, and zosinamide works on sodium and calcium, but I know some ones that I've seen a lot is valproic acid and acetazolamide. Okay, like I said, you can look into the pharmacokinetics, but they're not going to really test you so much on that. It's going to be, what are my contraindications, what do I teach my patient, and what are my adverse effects? So we already know allergy, hepatic, renal impairment, pregnancy, CNS problems, all of that, okay? CNS effects, okay? But for the valproic acid and divalproxil, remember, both of these work on GABA. They can cause liver toxicity, hyperammonemia, or too much like protein, thrombocytopenia, which means low platelets, so we got to put them on bleeding precautions, and pancreatitis. Acetazolamide and azonacinide, okay, they are both the ones that work on those electrolytes, so we're looking at rash and dermatological changes. Okay, and zonacinide can cause bone marrow suppression, right? So that means all of those we talked about, right? Musculoskeletal, what did we say about bone marrow? It produces red blood cells, white blood cells, platelets. So if we have bone marrow suppression, we really got to watch our CBCs. That's my nursing consideration, right? CBCs, anything that see bone marrow suppression, as a nursing consideration, monitor CBCs, okay? I would just read these over for drug-drug interactions, like quinidine, TCAs, but a lot of these are either CNS depressants or salicylates, right? Like aspirin, right? Bleeding, acetazolamide and zosinamide can cause, like, especially zonacinamide can cause bone marrow suppression. So, low platelets, bleeding, things like that, okay? And look at some of the other ones, diazepam, phenobarbital, primidone, phenytoin, all different types of CNS depressants and also seizure medications. So it makes you're seeing a trend here. Now, other medications used to treat generalized seizures, like the monoclonic, absent, things like that. Carbamazepine, I've seen this one a lot. It treats generalized and focal seizures. It blocks sodium channels. The thing I want you to know for this is actually a few things. One is that they can have aplastic anemia. What does that mean? Everything drops. White blood cells, red blood cells, platelets, everything. What are we monitoring? CBCs. Next, CNS effects and blood dyscrasia. So watch out for bleeding precautions. And something they always like to ask about this specific drug is it can cause something called Stevens-Johnson syndrome. If you see a rash, they must stop this medication. Okay, a rash is an indication that this is an adverse effect that's not supposed to happen. They can have this Stevens-Johnson syndrome, not good. Lamotrigine, another one I've seen a lot asked, especially on ATI. These inhibit those sodium and calcium channels to slow down those action potentials. Okay, adverse effects, CNS effects, and a life-threatening rash. Okay, so I would put unique to these two. They both can cause a rash that I really need to monitor for. So carbamazepine and lamotrigine, life-threatening rashes, not good. Now there's some other ones like levetiracetamine and topiramate. I would just read into these. I haven't seen as much of them, but pretty much the same sorts of things in terms of CNS depression. You know, you really got to be careful about pregnancy and things like that. But there's nothing unique that I've really seen for these, so I would just read them over. But focal seizures, remember we said those are the localized, it happens like one part of the brain. So these drugs can do a little different things. If they're focal seizures, right, we can either alter those sodium and calcium channels or increase the activity of GABA. You're seeing a trend in these medications, right? You can even, that's how also you can make a paper, right? Which ones work on GABA and which ones don't. The things with these is that always you have to be careful, right? With allergies, liver problems, pregnancies. I think an example is pregabalin. It decreases the effects of fertility. So what do we want to tell them? Hey, you know, if you're trying to become pregnant, use barrier contraceptives because it could cause birth defects. Okay? And adverse effects, right? CNS related, GI could be toxic to the liver, okay? I didn't see any focal seizure drugs, but I'm guessing it's like an example of like carbamazepine, since that one also can treat focal seizures, like generally like what they're talking about for this class in general, and always other CNS depressants, alcohol, or hormonal contraceptives.